went over this in lab for those of you in regular first year. You guys didn't need resources to review over stuff, but over cardiac stuff and people. I'm happy to send you some websites that are helpful. But it's going to be pretty basic, okay? Because we're not going to go into the rhythms in too much detail, because like I said, we've covered that before. But we want to know, how do we treat them? So we need to understand the dysfunction that can occur in the body leading to those arrhythmias, understand how different classifications of antidysphymics work, and understand the nursing considerations when using them. Okay. So first, let's just review the flow of conduction, right? So we have our sinoatrial node up here in the top of the right atrium. This is the pacemaker cell of the heart, right? It's the one that's supposed to be directing the show, leading everybody off. It's the conductor. So it sends off the signal, it is spread throughout the tissues as it then travels down to the AV node. The AV node is where the conduction is slowed just a little bit, right? Because we need to allow time for it to then travel down through the bundle of His and through the bundle branches and through ththose Purkinje fibers to send off the rest of the signals through the ventricles. Because they're so much larger than the atrium, right? They're going to need more time to coordinate in order to be able to pump effectively. So in order to understand how these drugs work, we need to think about the cardiac cells individually, okay? So we need to think about the action potential and what actually sets those cardiac muscles, those cardiac cells to contract. So we have sodium, calcium, and potassium that are always working in the cells, okay? When it is resting, it is more negatively charged, okay? And then, so we have our resting state, again, where it's very negative. As it starts to become more positive, then we have the depolarization, which is what? What happens when it depolarizes?
Sodium comes in.
We contract, right? Sodium comes in, and so that causes our contraction. But again, we need time for the cells to be able to coordinate, right? We don't want everything just contracting and releasing, right? Because we've got to have it spread the signals all throughout the tissues. We want everything to work together so we don't start to have those dysrhythmias and have things occurring too quickly so we're not effectively pumping. So then, after that sodium rushes in and sets off that initial charge, we start to go into repolarization, but we have, so that sodium goes really fast, the calcium goes slower. Okay, the calcium and the potassium start to exchange, and we have a slow repolarization that allows for more time to reset. And then the potassium, or the sodium and potassium finish off that exchange, and we go back down to that more negative state, okay? So really what I want you to get out of this is I want you to remember, again, sodium, calcium, and potassium. We need, in order to change what is happening within these cells, we need to affect the channels that those are traveling through, okay? So our normal electrocardiogram, we've got our P wave, and what does our P wave represent? So I hear a few of you saying it, you just aren't wanting to speak up. Right, so our atrial contraction, our atrial depolarization, right? And then we start to have our repolarization there, and then our QRS complex is what?
Ventricular depolarization.
Good, yeah, ventricular depolarization or contraction. And that continues on through our ST segment, because again, right, the ventricle is much larger. It needs more time to do its job than the atria. And then we start to reset again here. So when we look at a normal ECG, we need to remember that in order for everything to be normal, there has to be first a palpable pulse, right? Because we also have that pulseless electrical activity where we can have a beautiful picture here, but our patient is still dead, right? So we need to have a palpable pulse. Our heart rate needs to be between 60 and 100. There needs to be a normal shaped and sized P wave before every QRS complex. The PR interval needs to be between 0.12 and 0.2 seconds. The QRS, less than 0.12 seconds. And then there needs to be a T-wave. Okay? And then again, just remember that each of these small boxes is 0.04 seconds. And then that's how we measure the time that everything is taking. So some of our more common dysrhythmias. So our supraventricular dysrhythmias, right above the ventricles. So those are going to be those that are atrial in nature. So paroxysmal supraventricular tachycardia is one of our most common ones there. Our atrial fib and our atrial flutter actually fall under that as well, but they are really focused on the ectopic foci that we see with that, so we separate that out a little bit. Our ventricular dysrhythmias, right, so again, happening in the ventricles themselves, we have ventricular tachycardia and ventricular fibrillation. And then we have conduction AV blocks, and those you're going to learn more about next year. Okay, you'll learn about those in MedSurg too. So we're not going to focus on those as much because we don't need to slow things down with these ones because we already have issues with conduction through there. Okay. So as we again look at those ECGs, in order to make sure that we are evaluating what's going on, we need to look at what the rate is. What is that rhythm? Is it regular? If it is irregular, then is it regularly irregular, meaning that it follows a pattern? Or is it just doing whatever it would like and completely irregular? Again, is there a P wave for every QRS? Are they upright? Do they look the same? And then do all the QRS complexes look the same? And then are they all within that 0.12 seconds? And then is our PR interval again within our normal limits there for the 0.12 to 0.2 seconds? And then if it's not, is it too long or is it too short? Because that's going to be a defining feature there. Okay. So again, our supraventricular dysrhythmias, we have atrial fibrillation. So this is where we start to see that multiple ectopi, just different spots in the atria, are all speaking up, saying, hey, let's go. Right, and so we just have a bunch of jumbled there, and the atria start to quiver with that, right? So it's not effective pumping in the atrium. This is the most common dysrhythmia, and it affects about 4 million people in the United States. So it is one that you should definitely become very familiar with because you will see it a lot. Atrial flutter is very similar because we still have ectopi that are atrial focused, that are discharging, but it's more organized at this rate, but the AV nodes still can't keep up, right? So our QRS, our ventricles are doing their own thing while trying to keep on a normal pattern while we have this fluttering. So oftentimes we'll see the fluttering first, and that'll be kind of for a short time, and then they'll turn into the atrial fibrillation. And then that paroxysmal supraventricular tachycardia, so the AV nodal reentrant circuit. So instead of going from the SA node and then going down through the AV node and down, we have part of that pathway where it's going down to the AV node from the SA node or wherever this is originating from. Usually it's still the SA node. But then it's just sending it back up. It's just causing it to continue firing over and over again. Okay, so we end up with a heart rate that is between 150 and 250 beats per minute. Obviously not going to be super sustainable for long, right? People can sustain that kind of short term, especially if it is on that lower range. And sometimes we get our own heart rates up that high when we're nervous or doing a whole lot of exercise, although it shouldn't be there for long. But so we've got to fix that. Ventricular tachycardia. So we have rapid firing of the ventricles, often going to be at old infarctions. And again, what's an infarction? Right? Tissue death, right, in the heart. And we'll have, again, a rate of 150 to 250 typically with that. But we can have runs of VTAC, or we can have it be consistent. Do I have a pulse with VTAC? Maybe, right? So I may or I may not. So what is your very first thing that you need to do if you see VTAC on a monitor?
Check your patient.
Thank you. Check your patient, right? Because we need to know if they're alive or they're dead, right? Either way, we need to address this and we need to fix it, but we need to know if they have a pulse or not, right? Because it's going to change what we're doing a little bit here. Our ventricular fibrillation. So again, we have multiventricular ectopi foci, but it's asynchronous and the heart is only twitching, right? It's just got a little bit of quivering going on in there. Do we have a pulse with ventricular fibrillation? No, never. Your patient is always dead, okay, if we see ventricular fibrillation. Again, we definitely need to check our patient, right, because we need to make sure that this is accurate, because we can have leads that get moved or misplaced, or patients brushing teeth, right, and all kinds of crazy things that may make things look a little scary for a vet and hopefully not be as scary, but we need to know what we're dealing with. And then, of course, we do see premature ventricular contractions a lot as well. So those are ventricular beats that occur shortly before they should. So occasionally, right, we have the ventricles piping up and taking over for just a moment, and it's just acting quicker than it should. These are often benign, right? But if we start to have too many of them, then we're at risk for going into a VTAC or a VFib, right? It's kind of like a warning sign if we're starting to have a lot of them. Okay, a few here and there, not a super big deal, right? But we need to be looking for causes, because if there's something that we need to fix, then we do that. So that way we avoid going into this. So for our antidysrhythmic drugs, we use the Vaughan-Williams classification. Class 1 are those fast sodium channel blockers, right? Because the sodium enters very, very quickly into the cell in order to set off that depolarization. So this is going to slow conduction. We have 3 subclasses. I don't want you necessarily to focus too much on that as of yet, because again, they're sodium channel blockers, and that's really the part of it that you need to know. But class B, lidocaine, is the one drug that we're going to talk about a little bit more in here. Class 2 are beta blockers. We're already familiar with those, right? So these, of course, slow conduction as well. So metoprolol is one that we use commonly in there. And then our class 3 are potassium channel blockers. So as that potassium sets for that repolarization, if we slow the potassium exchange, then we're going to prolong the repolarization. Okay, we're prolonging the reset, so then it can't depolarize again as fast. And then our class 4 are calcium channel blockers. Again, right, our calcium is in the middle of that action there if we think about our action potential. And so if we slow those block those calcium channels, then we can slow the AV conduction. And slow everything down. So our sodium channel blockers, like I said, we're going to talk more about lidocaine here. So it blocks those sodium channels, reducing the nerve excitability. So again, you can't just continue to depolarize as quickly, and it raises that ventricular fibrillation threshold, okay? Because if it's reducing that excitability, then because we're not moving that sodium in as fast, then it, again, can't happen as quickly. So we're bringing that heart rate down, okay? We're slowing the process. Lidocaine, the one thing that's really nice about it, it kind of went out of favor for a while, and we really only focused on another drug that we'll talk about later. But lidocaine is one of our ACLS drugs again now for the last few years. But the nice thing is that it acts preferentially on the ischemic myocardial tissue, so it really helps with those. So this is going to be used to treat those ventricular arrhythmias. Because again, we need to decrease the rate of depolarization. We need to slow that down. Our nursing considerations, any of these drugs that we're talking about, if we are infusing them, which in this case, lidocaine would be an infusion. We're not doing it topically or as a block anymore. We're using it for cardiac function, right? Not for the anesthetic properties. And so we need to have our patient on cardiac monitoring. We need to do Q15-minute blood pressures. Anytime that we are having a patient on these types of IV infusions. And then we really need to watch liver function, because liver function is a big consideration with this one, because there's a lot of metabolization that happens very quickly in the liver with it. So if we have impaired liver function, the dosage may need to be decreased by as much as half. Okay, it is going to change your dosing. Our adverse effects, we can have bradycardia, we can have more dysrhythmias, because anytime that we are changing the conduction and the excitability of those cardiac muscles, not only can we fix dysrhythmias, but we can make them happen as well. Okay, so there's always a risk of dysrhythmias with any of the antidysrhythmics, which seems a little odd, but again, we've got to watch these levels carefully and really pay attention to safe dosing in order to make sure that we hopefully do not cause those. And again, that's why that cardiac monitoring is going to be so important, right? It can also cause hypotension. Why?
Because it reduces excitability.
Right, if we're slowing down the heart rate a whole bunch and now our body's trying to keep back up, then we can cause hypotension if we slow everything down too much. It can also cause some anxiety, and it can have a metallic taste for individuals. Just one of those things to note. So our contraindications are going to be a sinoatrial or AV block, Stokes-Adams, which this is a condition which causes a lot of bradycardias, and then Wolff-Parkinson-White syndrome causes a lot of tachycardic issues. But like really, if we have issues with conduction already, then it's going to put the patient at increased risk for further dysrhythmias, so we do not want to give these kinds of medications. Yes, Tina?
So if it's showing a block, is it permanently making a block, or is it just showing that, like it's, I guess like I can see blocks on a rhythm strip, and it could be from some of these medicines, but does that mean it's permanently making a block, or can it because it can't reverse, right? How does that?
We can improve stuff, but again, we're talking about blocks next year.
Okay.
We're not getting into all this today. So our potassium channel blockers. So amiodarone is one of our very popular antidysrhythmics. Okay, you will see this one used a lot if you end up either doing your clinicals or you end up working in an area that has a lot of cardiac patients, because again, it's very, very popular. So it delays that repolarization of the fast potentials to slow everything down, because again, it's working on the potassium, so it's spreading out that repolarization. And it's also going to block alpha and beta adrenergic receptors on the sympathetic nervous system. Okay, so we have some alpha and beta blocking effects as well. Okay, so with the multiple mechanisms, again, it's very popular because it works very well. This is used for both supraventricular and ventricular dysrhythmias. So you will see it used in code situations when we have a VTAC or a VFib arrest. You will also see it if a person has atrial fibrillation, especially with a rapid ventricular rate, right? So the heart rate's super high with an AFib. Then we need to slow all of that down. You will see this medication used for both of those things.
AFib and VFib.
AFib, VFib, VTAC.
Okay.
So again, our nursing considerations, right? We need to make sure that we are safely giving this medication, right? Because again, we're slowing down that repolarization, we're slowing down the conduction through there. So we have to have that patient on cardiac monitoring. Again, that is always going to be the case if we are giving these medications. Amiodarone can be also given PO, okay? So that person's gonna have like checkups at their provider's office and they're going to have EKGs. But if we're on an amiodarone drip, cardiac monitoring, blood pressure monitoring, and then we're also going to watch labs because it can affect, we can have some thyroid toxicity and some liver toxicity. So we need to watch the thyroid and the LFTs. Our side effects or adverse effects with our amiodarone. So phototoxicity or photosensitivity is going to be a common one. What's that? Right? Good. We can also have it put the patient into heart failure if they're already moving towards that way. We can have bradycardias and hypotension. Again, we're slowing everything down. The patient can become dizzy, right? Especially if, again, we're our bodies had to try and compensate for everything being really fast and high, then as we slow things down, then it takes the body a little bit to kind of reset and understand what's going on, right? So a lot of times we'll have that dizziness and struggle with that. Again, liver toxicity, thyroid toxicity, it could also be cardiotoxic, and pulmonary toxicity. So again, very dangerous drug, but you will see it frequently used. Again, if there's heart blocks, we are not going to give this. And if there's hypersensitivity, if the patient's had it before and had a reaction, then we should probably not choose this, and the provider should pick something different.
Are you still doing the every 15-minute blood pressure check?
Yes. Anything that you are infusing that affects the heart, you are going to be doing continuous cardiac monitoring and every 15-minute blood pressure checks.
That's specifically with infusion.
Mm-hmm. Right, because we need to know if we're having those adverse effects. If I'm not checking that blood pressure but once an hour, every couple of hours, I could completely tank my patient's blood pressure, and I could cause a whole host of other issues and not even know it, right? So we have to be continuously monitoring all of that. Our calcium channel blocker, the one that you'll see frequently used, is diltiazem. Okay. So for the calcium channel blockers that we're talking about today with the diltiazem, this is different a little bit than the calcium channel blockers that we were talking about yesterday with hypertension and heart failure. The ones that we were talking about yesterday were the dihydropines, okay? And so those mostly work on the smooth vessels in the blood vessels to actually cause that vasodilation, okay? These non-dihydropines that we use in these cardiac for the dysrhythmias are going to affect the heart cells as well, okay? So we still have the vasodilation, but we have them working on those calcium channels within the heart cells themselves as well. Okay? So a little bit of extra action, okay? So these temporarily control those rapid ventricular responses in AFib flutter, as well as the paroxysmal supraventricular tachycardia. So you can use that for that as well. Again, we'll have to have cardiac monitoring. There can be postural hypotension, and this can affect your potassium levels, so we need to watch those. Okay. Our side effects and adverse effects, it can cause some GI effects of constipation. We can also have bradycardia. If a person is already kind of on their way towards a heart block, then we can have that cause that. We can have hypotension, again, dizziness, and dyspnea. Okay. So our contraindications, if the patient has an acute MI, we are not using this drug. If the patient has pulmonary congestion, we should not be using this drug, because again, it can cause dyspnea, it can cause some pulmonary effects. If we have severe hypotension already, then of course we don't want to give this, because it is going to bring that down as well. Or if they're in cardiogenic shock, or again, any of those conduction issues, right? Any of those kind of blocks. We need to be very, very careful that we are looking at those EKGs and that we are kind of deciphering those beforehand, and that the correct providers are taking a look at those to look for a history of blocks. Really, because when we're looking at these super fast rates, we're not really going to be able to see these, right? Because everything's moving too quickly, so we need to look at past records to know that we can safely get this. So hopefully we have them, right? We don't always, which again is why we have to just watch the patient very carefully, because if they start to show signs of those issues, then we need to stop these drugs. Then we have an unclassified antidysrhythmic. It is called adenosine. Is one of my favorites. It works on, there's actually adenosine receptors within the AV node, and so it temporarily blocks the AV node. It has an extremely short half-life. It is less than 10 seconds. So this is a very quick blockage of the AV nodal conduction. So we're allowing for the heart to have a little pause to hopefully reset and go back into a nice normal rhythm that we like, okay? Again, that SVT is way too quick, and our body can only keep up with that for so long, okay? So our nursing considerations, because this has such a short half-life, we have to give it extremely fast, okay? It has to be in a large bore IV, so it needs to be in an 18 gauge or bigger. It needs to be the AC or closer, okay, because it needs to be able to reach the heart very quickly. And we're going to flush it through very quickly as well. So a lot of times when we do this, we will either hook up a little bolus bag of maybe 100 mils or 250 that we can even squeeze after we slam that adenosine in. Or if the patient is more sensitive to fluids, right, depending on what else is going on with them, then we would hook up literally, typically like 20 milliliters of saline into a stopcock. And so we would have that set on one side, so a little, right, just like the Lopez valves that we talked about, but this is for an IV, okay? So we have the flush ready to go, we have our adenosine, so we turn it off to the flush, we slam that adenosine and switch that stopcock over, open it up to where the flush goes in, and we slam that in quick too, okay? If we're giving it into the AC or higher, we are going to raise the arm. We want gravity to be our friend. So we're doing absolutely everything that we can to make this reach the heart as quickly as possible, because that's where we need those effects, okay? If we give this slowly, it is not going to work. You have just wasted a drug. It's not gonna do its job, okay? So again, it's less than 10 seconds, so this person has gotta be on cardiac monitoring because we're watching for that change. We need to have a crash cart in the room, ready to go just in case, because this can cause a dysrhythmia as well. We also, if they have some other underlying disease that we're not aware of, it is very rare, but it can cause arrest, it can cause anaphylaxis. So again, we need to be prepared, and atropine as well, because of course it can cause severe bradycardia as well if it doesn't reset correctly, okay?
Does our patient, like, how does that make them feel? Like, does it?
So our adverse effects and our side effects, again, it's short-lived, so it's not for long, but it can cause sinus bradycardia, it can cause dyspnea, they have chest discomfort, they get flushed in their face, and they can have hypotension. They will feel it, okay? But it's very strange because you're watching this monitor as you hurry up and slam that in, and you get it going, and you're watching it, and you should see actually a little pause, and then hopefully that reset, but your patient's just staring at you, just feeling awful. It makes them feel miserable, not even gonna lie. Thankfully it's short-lived. They're just staring at you and waiting. I had one time where I gave this and it took about 12 seconds for the heart to reset. Okay, and again, this is supposed to wear off in 10 seconds or less. So I'm there with the cardiac surgeon, who was the primary on this patient. We have everything ready to go just in case. I slam this in, I'm watching the monitor, and I'm like, okay, and I'm counting out the seconds, and I lean forward to start compressions. And thankfully, whoop, we get a nice little rhythm back, okay? It is an amazing drug. It is a little terrifying, but it's also a lot of fun to give, because when it works, it's great.
So when you're educating the patient, like,
You're telling them that this is going to reset your heart. It is going to feel miserable.
Okay.
You are going to have some chest discomfort. You're probably going to feel really flushed. It's going to feel awful, but it's going to go away really quick. Okay?
Do you usually educate after you've given it? Or because you're in an emergency situation?
I mean, it's usually not the person dying at that moment. It's just a little reset.
Okay.
But so usually I'm educating, because this is an
As you're
emergency
giving it.
situation, as I'm setting it up, right, getting my bolus ready to go, because again, I need to make sure that I've got things ready to flush it in real quickly afterwards. So we multitask a lot in these situations, right? So I'm telling my patient about this as I'm setting everything up.
After you give it,
Mm-hmm.
and then, like, if it fixes or, do they feel exhausted?
I mean, usually people that have had severe enough SVT, in this case, to need adenosine are, I mean, their heart's been racing and racing.
Right,
So yes,
okay.
right?
Is it
They're gonna
after
feel
they breathe
exhausted
down?
already before that too.
Okay.
Um,
Don't
yeah,
patients
but it's a-
state like they're dying, like they're slowly dying until it resets? I've heard that's what it feels like.
I mean, yeah, like I said, they feel awful. It does make a person feel truly awful. Again, it is really, truly, like, it is causing a complete block of that AV node for a very short period of time to go through there. Sometimes we have to give 2 doses, but that's the max you give of it. Okay? Yes, 2 doses.